So we go on to our next speaker, Dr. Ravi Challa, a leading cataract and refractive surgeon, a pioneer from Hyderabad, to give us his pearl, and a good one at that. So let's hear from you, Dr. Ravi.
Yeah, this is a routine stop and chop case which turns strange.
Interesting case here. So of course this is a white mature cataract, and he's going to use the double rhexis technique. He's going to make a small central capsulotomy, and notice this is done with just a paracentesis incision, so then the anterior chamber is highly pressurized. Then the second rhexis can be done afterwards, and you can see that looks beautiful. Beautiful rhexis here. Sculpting a central groove now for a stop and chop type procedure. Everything looks pretty routine in this case. So nice good central groove, and then going to crack this and split it into two halves. And as a result of having a thick fibrous posterior plate, you don't get a good separation here. So that's, you see the nucleus is split, but not centrally. So now more viscoelastics going inside the eye, and then he's going to use a couple of Sinskey hooks to do some manipulation, try to separate the nucleus. Here's where I want you to watch very carefully. As the two halves are separated, look how far apart they are. Look at that huge gap between the two pieces. Wow, where's the piece that's sub-incisional? There's that last bridge that's being broken. Now we have two fully separated halves. But where's the proximal heminucleus? It's under the iris in the subincisional space. Where did the nucleus go, the heminucleus? Well, half of the heminucleus has gone through a defect at the capsular bag equator. So the subincisional capsular bag equator. So the surgeon here, Dr. Challa, is going to phacoaspirate and remove, chop up the first heminucleus. Going to just take his time there. And again, the second heminucleus is still under the subincisional iris. Very unusual case. To have a break or a violation of the capsular bag at the equator is very unusual. I'm very thankful for Dr. Challa for sending this case, because this is something you don't see very often, at best once every few thousand surgeries. So now only half the nucleus is gone. One heminucleus is gone. The second piece is still there, and it's underneath the subincisional iris. Look, it comes forward. As the anterior chamber is depressurized, that piece comes forward again. So as you pressurize, it disappears. So we need to get that piece up. Under the iris goes this Sinskey hook, and we're going to bring that piece centrally. And Dr. Challa is going to just take his time here, and he's going to do a beautiful technique here. And it's still stuck. There's the heminucleus. You can see it. Now, we don't advocate fishing in the vitreous cavity. That's going to cause issues. But here he's doing it in a very safe manner, and the piece is not in the vitreous cavity. It's through that defect, but it's not floating in mid-vitreous. And here he successfully brought the second heminucleus up, more viscoelastic, create a barrier, keep that second heminucleus up. And he's also very smartly using that nasal angle, keeping that piece pushed against the nasal angle is very good, because that prevents it from slipping through the pupil. We don't want that to happen. I'm really happy that we're able to watch and learn from this masterful technique. It is absolutely safe. Now, would I have faulted you if you said just let the piece go back and have my vitreoretinal colleague do a pars plana lensectomy? No, that'd be perfectly fine. And in some cases, if you're unable to reach the piece, I agree. Let it go. Don't fish for it. So now that the nucleus is entirely removed, he's going to fill a capsular bag here. He's going to insert the lens. So there's the viscoelastic being put in the eye. Here comes the IOL. Now, what are your options here? He's going to do a hydrophobic acrylic single-piece lens in the capsular bag. As long as you rotate it 90 degrees away from that defect, I think you'll be okay. Other options would be a 3-piece lens in the sulcus, again with the haptics rotated 90 degrees away from the defect. And finally, at the end here, the viscoelastic can be removed. So, very good technique. We really enjoyed this very unusual case. Again, capsule rupture or capsule defect at the capsular bag equator in the subincisional area, and half the nucleus disappeared and then came back. And at the end, it ended up beautifully. Thank you for watching.
Dr. Ravi, that was can stop sharing. That was a wonderful video, which
Suitable stuff.
again is going to do a lot of discussions.
Challa.
My thought about this particular case was that must have been a very small PCR, and the vitreous would have been a jelly-like structure there, and so you could do it. But one thing you could have, while hunting out or scooping out that fragment, you could have actually placed an iris hook to get a better visibility rather than digging there. The other thing is, we also need to keep in mind at this point that if that area of PCR were to increase, these are the cases where we could do a pars plana vitrectomy so that you contain that area of PCR, it doesn't become big. My second thought was, since we know that the nucleus has sunk there, we know there's a PCR there, when you brought it out into forward into the capsular bag, probably you could have thought of putting an IOL scaffold in these eyes, because that was a fairly large chunk, and then going ahead and removing it. I want the thoughts of the experts in this.
I have a point to make. I don't think there is a PCR. If the PCR is there, the posterior capsule will not be taut, and the red reflex is clean. No creases in the posterior capsule also. So it must have been a rent in the equatorial region only. So the zonules are holding the anterior capsular rim and the posterior capsule also. So that's why posterior capsule is taut throughout the procedure.
No.
So I also
Is
feel that there was
the patient a high myope?
vitreous could have come
I don't remember.
Challa.
So
what was the power of what was the
case, I
power
don't
of the
remember.
lens? What was the power of the lens that you would have put?
Yeah,
Because
the patient high myope, that's why.
yeah, if he's a high myope, then the lens in that case would go underneath the iris and only come out when you deflate the anterior chamber and it kind of becomes shallow. Then it keeps popping out. Also, I think when you can't get a full hemisection like that, then it's best not to attempt to make it a hemisection. You can just have a crack there like a pie or like a pizza thing, and then carousel it, and then I have another one and take that pie out rather than trying to make that 180 degrees cut from one end to the other end.
Yeah, Chitra, can I add something?
Yeah.
Yeah, first things first. Challa, fantastic video, is really incredible stuff. But I want to know why, see, the stop and chop, especially for a hard cataract like this, you need to go all the way down, almost 90-95%, and then try to crack. Then when you're cracking, when you're doing the first crack, I noticed you are more anterior than posterior. You need to go posterior and crack. Then only it will crack nicely. If you're anterior, every time you crack and go to lateral separation, there'll be stress from the zonules. So that is what has happened probably. And then again, you try to crack and go in and crack with a second instrument or a Sinskey hook or something like that. But again, there was so much of pressure on the lateral, the vector forces were very high. And that is probably the reason for the zonule, this thing. Third thing is, I agree with Chitra, because when you see something underneath the iris, I'll put one or two iris hooks there and know exactly what is happening there. Okay, so, because I never saw you using tricot at all. How do you know whether the vitreous is there or not? We do not know at all, because you have so much of manipulation is there. 100%, you cannot just have a nucleus there lying there in the equatorial space without the vitreous coming in front. So I think these are all the small points, but otherwise beautifully handled.
Om Prakash had a presentation similar. That could also have been an area of zonular weakness, and because that nucleus fragment was there, it was pushing that area of zonular weakness. So you can never be sure that the vitreous will not come forward in that area.
Yeah,
Dr. Rohit, do you have anything to tell there?
I think it was a very nicely presented case.
Yeah.
Well, if you are not able to separate, just forget about it. Move ahead and chop other pieces eventually, and and then you can, while emulsifying with the stock, joint, you can emulsify the stock and the pieces can be separated. Separation should not be that aggressively managed in all these patients. The second thing, which it's something which I would like the discussion to be initiated. I have seen that in some patients wherein the hyaloid, if you have a PCR, the hyaloid face is intact. Suddenly you feel that the nucleus has gone behind. And suddenly when the chamber collapses slightly, the nucleus piece comes up on its own. So if the hyaloid phase is intact in some cases, the nucleus piece behaves in a very extraordinary way in coming up. But once it is broken, then, it goes, there's no idea of fishing. And I fully agree with Dr. Mohan Rajan, by all means, that this separation would have led to some equatorial, the capsule giving away, and having a view with an iris hook or whatever it is would have been obligatory and mandatory rather than, just trying to pull it out.
Just one more thing, Chitra. Dr. Vasavada has described a beautiful technique of multi-level chop. So if you are anterior, which like Dr. Mohan Rajan said, and it's not splitting, go a little more down at step down and with the help of the phaco probe, and then again try. Then, it kind of works out.
I think I'll be just reiterating what was said in the sense that, what Navatra said may be applying to phaco chop, but as far as stop and chop, which is still widely practiced, the only thing I would have done differently is if it did not chop easily, I would have gone back again with a phaco probe and made a trench much deeper instead of putting in so much power on splitting the heminucleus. And also, as was emphasized, I think going into the depth of the nucleus is extremely important so that it just simply gives way and there's hardly any stressing. And I feel that maybe what he did was absolutely right in the sense that posterior capsule is intact and that there was no vitreous disturbance. And as the chamber shallows, the nucleus fragment just floated into view and he went ahead and completed. Maybe there was a capsular dialysis in the periphery, but that would not have changed the management of the case, especially since he's positioning the haptics away from that area.
If there was a dialysis, you should position your haptic there to keep it stretched, a 3-piece IOL for that matter. But that was a wonderful case, Dr. Ravi. I was so excited when I saw that there will be a lot of discussion.